Bismillahirrahmanirrahim. My name is Dr. Ziaul Haq, Assistant Professor of Pulmonology at Gaji Khan Medical College, Sawabi. Today we are going to discuss the second topic of this year of pulmonology, which is acute respiratory distress syndrome. In last lecture, we have discussed the pulmonary function test. You all know that this is very much important for the students and doctors to know about the pulmonary function test while dealing with the patient of the chest diseases. This is the tidal volume, which is the normal air going in or out during resting position. And this is the inspiratory reserved volume, which is the maximum air which are inspired or inhaled after normal inspiration. And this is the vital capacity, the amount of air exhaled after maximum inspiration. And the inspiratory capacity, this is the inspiratory capacity, which is the uh, amount of air expired after maximum inhalation, but after normal exhalation. And this is the residual volume, which is the amount of air left in the lung after maximum exhalation, while the functional residual capacity is the amount of lung volume after normal exhalation. And the total lung capacity is the amount of air left in the lung after maximum inhalation. So this was a recap, and you should remember this. Now we will moving on to the today's topic, and we will start from this case scenario, which is a 57-year-old male who presents to the hospital with a 1 week history of high-grade fever. Fever started 4 days after attending a marriage and wedding hall. Over the last 24 hours, he has become progressively unwell with more severe cough and mild confusion. At 8 a.m., when he refused to get off the bed and his lips looked blue, his wife called the ambulance. So this is the history, chief complaints of the attendant of the patient. One is high-grade fever, which is for the last 1 week. The other is cough and confusion. And the other is bluish discoloration of the lips. Upon arrival to the emergency room, he was in obvious respiratory distress with a respiratory rate of 40 and saturations 85 and double flow non-rebreathing mask. He was started on CPAP by the emergency physician. CPAP is continuous positive airway pressure, which is a form of non-invasive ventilator. But patient was not tolerating the CPAP, and saturations further decreases to 65%. Then he was put on mechanical ventilator, which is invasive ventilator. His blood pressure dropped post intubation, requiring phenylephrine, and has now received 2 liters of normal saline. So this was a short history. After intubation, he is just being placed on the ventilator by the respiratory therapist. He is stated stable by the bedside nurse. His saturation was 96% on 100% FiO2, which is fraction of inspired oxygen. His blood pressure was 110 by 54 millimeter of mercury. Heart rate was 130 and temperature was 36.2. His physical examination reveals crackles in his bases bilaterally. His skin is mottled and cold with no rash. Neurological examination was normal. Cardiovascular, abdominal, genital, external exam and non-contributory, meaning that was normal. Initial chest X-ray shows bilateral bibasilar infiltrate, and ECG was done, which showed sinus tachycardia, is shown by the pulse of the patient, which was 130. This was the chest X-ray of the patient. Here in this X-ray, you can see the infiltrates. These are the infiltrates on right side, and these are the infiltrates on the left side. These whitish lines are called the infiltrates, linear lines. These are the probes. Okay. So what comes in your mind? What this patient is suffering from? अगर आप देख ले आजकल हमारे पास जिस जिस तरह पेशेंट आते हैं, तो ये एक एक्चुअल एक सिनेरियो है पेशेंट्स. अच्छा जी. तो आजकल हमारे पास पेशेंट आते हैं, इस तरह हिस्ट्री होती है कि मैं बिल्कुल ठीक ठाक था 7 दिन पहले, अचानक मैं एक शादी पर गया था या किसी जनाजे पर गया था, उसके 4-5 दिन बाद मुझे बुखार शुरू हो गया. तो फीवर, 1 हफ्ते फीवर था, उसके बाद फिर शॉर्टनेस ऑफ ब्रेथ और कफ, और फिर जब हम एक्सरे कराते हैं तो एक्सरे इस तरह होती है. ठीक है, तो ये एक्सरे होता है कोविड पेशेंट का, कोविड निमोनिया का. और दूसरा, अगर हम इसको नाम दे दे, बिकॉज दीज आर इनफिल्ट्रेट्स बायलैटरली, बेजल भी है, इनफिल्ट्रेट भी है, तो ये दिस इज वन टाइप ऑफ एटिपिकल निमोनिया. कोविड causes एटिपिकल निमोनिया. अच्छा, the resident feels this is a pneumonia and comments that it likely meet criteria for acute respiratory distress syndrome. A medical student then speaks up and asks, what is ARDS? And what is the definition of ARDS? What is the epidemiology of ARDS? And what is the pathophysiology, clinical stages, and likely causes of ARDS. Because medical students are interested in passing exam, and an exam usually these questions are asked during paper or viva. So we will discuss the background of ARDS. During 1960, during the polio pandemic, there were widespread use of positive pressure ventilation, which was a distinct form of bilateral, and there was a distinct form of bilateral lung disease was noted. At that time, this disease was named as shock lung because during polio pandemic, first time ventilator were used and positive pressure were given and the lung were named as shock lung. And also the name was renamed during Vietnam Surgical Hospital to the trauma patient. After that, this was named as adult respiratory distress syndrome, and currently this is described as acute respiratory distress syndrome. So the current name of ARDS is acute respiratory distress syndrome. For more than 20 years, there was lack of a, a uniform description of ARDS. In 1994, American European Consensus Conference on ARDS issued the following definition for one is acute lung injury, that was acute lung injury, and the other is ARDS, which is acute respiratory distress syndrome. The definition of ARDS is, as we know that there is not a single definition of ARDS, we have a criteria which or a criteria of ARDS which is comprising of four things, four important points. Point number one is there will be bilateral radiographic infiltrates in patients of ARDS. The partial pressure of oxygen by fraction of oxygen, this ratio will be less than 300 regardless of the level of the positive and expiratory pressure. So there will be decreased oxygen, partial pressure of oxygen. And there will be no clinical evidence for elevated left atrial pressure. If measured, the pulmonary capillary which pressure is 18 millimeter of mercury or less. And by definition, this will be acute insult within a week. Typically, it will develop over 4 to 48 hours and will persist for days to weeks. So, number one is acute in onset, less than a week insult, like fever, like any infection. The other is there will not be heart failure, but the X-ray finding will be similar to heart failure. And the PaO2 by FiO2 ratio will be less than 300. In pathophysiology of ARDS, and healthy lung, a tight regulation or movement of fluid to maintain dry alveoli, and a small amount of interstitial fluid will be there to prevent from the atelectasis of alveoli. So there will be a tight regulation. And lung injury, this regulation will be lost. There will be excessive fluid in alveoli and interstitium, which will impair and the gas exchange and will decrease compliance, and it will increases pulmonary arterial pressure. In this image, if you can see on left side, this is normal alveoli. These are the bronchial epithelium, which is lying uh, in a good way. These are the type 1 cells, these are the type 2 pneumocytes, and these are the alveolar macrophages. This is the capillary in which blood goes. On right side, this is the lung injury alveoli. Here, these are disturbed. The bronchial epithelium is disturbed. There will be the necrotic type 1 cells. The, there are cellular debris, and the pneumocytes, type 2 pneumocytes, will be proliferated, and hyaline membrane formation will start, and the fluid from the capillary will goes into the interstitium and the alveoli, and also the cells, macrophages, monocytes will goes to the interstitium and alveoli and starts the inflammatory reactions, further damage the alveoli. This is the normal uh, histological image of the alveoli of the lung, and this is the image of the ARDS. Everything is disturbed, and you can see the proteinaceous material, the cells. So, what will be the consequences of this ARDS? It will lead to the impaired gas exchange, which will be the ventilation perfusion mismatching and leads to the shunting and will not help in oxygenation. And there will be decreased lung compliance. The lung will be stiff. Low compliance is due to stiffness of poorly or non-aerated lung, or sometimes that is called the baby lung. And there will be pulmonary hypertension, which is present in up to 25% of patients with ARDS. Now we will discuss the clinical stages of ARDS. It has three stages. One is exudative stage, in which there will be diffuse alveolar damage and exudation of fluids to the interstitium and alveoli. And this stage will progress to proliferative stage, which is characterized by resolution of pulmonary edema and proliferation of type 2 alveolar cells, and squamous metaplasia, then leading to interstitial infiltration by myofibroblast and early deposition of collagen. So this is the proliferative stage. And the third stage is fibrotic stage, which is obliteration of normal lung architecture of the lung, and diffuse fibrosis will be there, and sometimes cyst formation. In this image, this is the exudative stage. First is exudative stage. Here, in first to 3 days, there will be exudation of fluids to the interstitium and alveoli. After this, the hyaline membrane formation will start, which is the proliferative stage. Type 2 pneumocyte cells proliferation will start. In the third stage, after this, there will be fibrosis of the lung. If you can see the chest X-ray of the stages, an exudative stage, there will be dense shadows on chest X-ray, which will be bilateral in first week. Here, you cannot differentiate this X-ray from the X-ray of left ventricular failure, left heart failure. So that's why we say, or the criteria of the ARDS says that this finding should not be due to the left ventricular failure. This is the X-ray of proliferative stage. The density of the X-ray has been reduced. Still, there are some dense areas. And this is the reticulation bilaterally. These are the reticulation. These are the reticulation. On X-ray basis, we cannot differentiate between the proliferative stage and the fibrotic stage. These are the histological findings. What are the conditions which are associated with ARDS? Sepsis, aspiration, which may be chemical or gastric aspiration or gaseous, some inhalation, infectious pneumonia, like we have discussed, which are maybe bacterial, viral, or fungal, or severe trauma, surface burns, multiple blood transfusion, leukoagglutinin reaction, pancreatitis, drug overdose, near drowning, and smoke inhalation can be associated with ARDS or can cause ARDS. How we can diagnose ARDS? History is important. Like we have discussed that 4 points are important for the definition and diagnosis of ARDS. One is history. So history is important. The other is chest X-ray or HRCT to know whether there are bilateral inflammatory bilateral infiltrates on X-ray and HRCT. We do BNP, brain natriuretic peptide, echo, and pulmonary arterial catheterization. These three tests are done to rule out heart failure, and arterial blood gases as well to know the PaO2 by FiO2 ratio. Sometimes we do bronchoscopy and ARDS patient. This is just an image, not the patient of ARDS, because ARDS patient will be on CPAP or invasive ventilator. Now we'll discuss the management of ARDS, which will be divided into the supportive care and the treatment of the cause. In supportive care, we will give oxygen. Initially, oxygen are given on the basis of the demand of the patient. If patient demands 1 to 5 liter of oxygen, then we give oxygen through nasal cannula. If patient needs more oxygen from 5 to 10 liter per minute of oxygen, then we give oxygen through face mask. And when he or she required oxygen 10 to 16 liter per minute, then we give through non-rebreathing mask. After that, we can give through CPAP, non-invasive ventilator, or if the patient cannot maintain saturation or PA, partial pressure of oxygen, then obviously invasive ventilation is indicated. Also, we can look into the intravenous fluids of the patient to maintain the intake output record, because we will not give extra fluids to the patient. And on the other hand, we will not deplete the patient from the fluid in order to prevent acute lung injury due to low fluid volume. And we will, good nutrition is important. Will give DVT prophylaxis in the form of heparin or enoxaparin. Peptic ulcer prophylaxis, oral or IV proton pump inhibitors are recommended, and steroids use is controversial in ARDS. But in COVID cases, steroid will reduce the mortality up by 10%. So steroids are indicated in COVID ARDS, but in other types of ARDS, steroid use is controversial. Okay, this is an article which was published and said that don't give extra fluids to the ARDS patients. And during management of ARDS on mechanical ventilator, we will use the lung protective mechanism like lower tidal volume and higher PEEP in order to reduce the risk of barotrauma. Sometime, very rarely, lung biopsy is recommended in ARDS. Usually, we don't do lung biopsy in ARDS. Prone ventilation or prone positioning is extremely important, and we have seen this in COVID management, both awake proning if the patient is not on CPAP or ventilator, and also unconscious proning when the patient is on sedation and paralysis and patient is on ventilator. This will improve oxygenation because the maximum lung is present on the back surfaces. When you prone the patient, you will free the lungs from the pressure of the heart and the chest walls. So oxygenation will improve when you prone the patient. If patient is on ventilator and not improving oxygenation despite of maximum efforts, so there is a machine which is which named as ECMO, extracorporeal membrane oxygenation, which is a type of lung bypass machine. In this machine, the blood is two cannula is inserted into the patient, and from one cannula blood is coming to the machine, and blood is mixed with oxygen, and carbon dioxide has been removed from the blood, and on the other cannula the blood is traveled to the patient. So this is a type of lung bypass machine. The aim of this machine is to give some time to the lung to rest and heal. Now we will discuss the complications of ARDS, which could be barotrauma and nosocomial infection, which is called hospital-acquired infection. It may lead to multiple organ failure, deep venous thrombosis, and untoward effects from sedation and paralysis like myopathy, muscle weakness. Mortality of ARDS is 41%. This is very high mortality. So it means ARDS is extremely critical condition. Summary of my presentation is respiratory distress is the hallmark of ARDS, including cough, shortness of breath, chest pain, cyanosis, and tachypnea. ARDS has pulmonary and extrapulmonary causes. Treatment depends upon good nursing and ICU care. Some patient has lifelong lung functions impairment despite of treatment. Thank you.